Welcome to the rapid fire session. What a great meeting this has been. We hope you are planning to join next year for the 49th annual meeting scheduled for September 18th to 20th, 2025 at Hotel Cincinnati, Netherland Plaza Hotel in Cincinnati. So definitely go ahead. I always recommend you guys put it on the calendar now. You guys have been here for the meeting and you stay until the very end, so you must realize this is a great meeting to be at. Cincinnati's supposed to be pretty fun. I know it's not Chicago, Ross, but we'll have a good time. Muck will throw on a pretty good party. So you guys keep an eye on the website. There's always going to be information about hotels and stuff like that. So keep an eye on that. We are going to have a change in the schedule. Somebody is traveling, so I think we will switch it out a little bit. I think what I'll ask is the first person, and that's all I have here. Dr. Mohammed Charao will be first presented today for his talk on the single center experience with access-related complications in patients undergoing transcatheter aortic valve replacement. Dr. Charao. So make sure you guys, so everybody in the room, you have a 3-minute clock there. I heard Natalie's pretty mean. She'll kick you off the stage. I'll try to protect you, but keep an eye on the clock, guys.
Thank you so much for giving me the opportunity to present this work. We have no disclosures. So despite advances in TAVR devices, sheaths required for the delivery of the valve are still big at 14 to 18 French. This is why we continue to have access-related complications, with rates reaching up to 6%. The objectives of this study was to describe our center's rate and types of complications, identify management strategies, and explore possible predictive patient risk factors. This was a single-center study in which all TAVRs done between 2020 and June 2024 were retrospectively reviewed. A descriptive analysis of the experience was then performed. 855 procedures were performed. The rate of access-related complication was 5.5%, 4.9% at the primary site, where the big sheath is present, and 0.6% at the secondary site, where typically a 6 French sheath is present. This pie chart above shows that the most common complication was a dissection in 45% of cases, followed by bleeding in 31%, followed by stenosis and pseudoaneurysms in 12% of cases each. Complications were managed using a combination of open and endovascular treatments. Dissections typically required angioplasty or stenting, but were sometimes managed conservatively if they were non-flow limiting. Bleeding required cut-down and primary repair when it was due to failure of closure device, and required stent grafts, including TEVARs, when there was bleeding from more central artery perforations. Stenosis and occlusions required angioplasty, and in some instances, cut-downs and thrombectomies. Finally, pseudoaneurysms were typically treated with thrombin injection. It's important to note that 83% of cases were managed by vascular surgery after intraoperative or postoperative consult. Looking at patient characteristics, we found that in 26% of cases, the femoral artery was at least moderately diseased on preoperative CT. We also found that 58% of patients with complications were on the extremes of BMIs, either less than 20 or more than 30. Some other observations included patients with severe aortoiliac disease, patients who had previous operations on their groin. And all those are risk factors that are known to increase risk of access-related complications. At our institution, and in an effort to decrease complications, our cardiology colleagues are now referring patients with these risk factors to us before the intervention for a discussion of ideal access. We are planning to check our outcomes in 1 year to see if this can decrease the rates of complications. In conclusion, our study shows that vascular surgeons are needed in all centers performing TAVR to manage access complications. In addition, pre-op vascular surgery consults should be considered in patients deemed as high risk, mainly to discuss open or alternative access. Thank you so much. Happy to take questions.
You can stay for questions, or you don't have to go right now.
Yes.
Okay, good. Dr. Milner.
Yeah, nice talk. We actually, I think every center have seen this. Our team now has put together a multidisciplinary team where we try to meet in person, but we do meet virtually every once in a while ad hoc and look at every single one of these cases for access. And sometimes we just write in and say there's no access issue and we don't need to be there. But we've looked at this, and exactly as you described, because of the alternative access options, and we can assist with that, we've participated in the clearance of almost every TAVR patient again, which takes us back to when this first started, I realize, but it prevents these problems.
Thank you so much. Yeah, at our institution, we have not formalized it as in like a multidisciplinary in-person meeting. It's usually the cardiologist giving us a call saying, hey, can you look at the CT scan? We're thinking this is going to be a complex case or a complicated access.
So I'll ask a question. I think most of the vascular, these trainees in the room think the complication rates for TAVR access is probably like 50% because you get called so much. But what do you think, what you found in the literature is what is acceptable? Because, 5%, and it depends how you classify it. You can give us a little insight on that.
Absolutely. So if you look at the STS reviews from the Society of Thoracic Surgeons, because all TAVRs are now included in those, you would see that the rates are somewhere around 6%. Which is also, as a matter of fact, not very far away from what we see in vascular access whenever we're planning to do endeavors. And as you can tell, the access sheet is kind of similar, 14 to 18 French. VQI 2020 paper showed that the access rate, complication rates, is around 4.6%, so not so much far away from this.
Great. Thank you for your time.
Thank you so much.
Next, we're going to hear from Sophia Trin, open versus endovascular repair of traumatic subclavian arterial injuries.
Thank you for allowing me to be here today to present my work. So yes, I'm Sophia Trin. I'm with LSU. I'm a fourth-year general surgery resident. So today I'll be presenting my study on open versus endovascular repair of traumatic subclavian arterial injuries. I have no disclosures. So these injuries are relatively uncommon. They come with a high morbidity and mortality. Traditionally, they were repaired with open surgical approaches, but however, in the kind of more recent years, endovascular approaches have become more common. So we aim to compare the outcomes between open surgical and endovascular repair of these injuries. So how we did this was it was a retrospective single-center study looking at data from a level 1 trauma center registry. It was for 10 years, so from July of 2012 to July of 2022. All patients greater than or equal to 18 years of age with documented traumatic subclavian arterial injuries were included. Our primary outcome was mortality, and our secondary outcomes were hospital and ICU length of stay as well as amputation rates. And for statistical analyses, we used Wilcoxon rank sum as well as a chi-squared. So we ended up with 45 patients with these injuries. 2 had expired in the emergency department, and 7 were managed with anticoagulation alone, so they were not included in our analysis. So we ended up with 36 patients, 22 with open repair and 14 with endovascular repair. And as you can see in table 1, so the indications for the open repair, mainly 8 of these patients, it was due to hemodynamic instability. 4 of them was because of an enlarging hematoma. And then 10 was kind of for some other unknown reasons, mainly from what it looked like was physician preference or arterial bleeding. And looking at table 2, you can see the demographics of our 2 groups here. There wasn't really any significant difference between the demographics other than the amount of blood that was transfused. So it was significantly higher in our open group. And then the mortality, which was also significantly higher in the open group. And one thing I found interesting was throughout our 10-year study period, there wasn't really a linear trend in the use of endovascular use. So you can see it's kind of sporadic. So in conclusion, there was no difference in hospital or ICU length of stay between our 2 groups. However, there was a higher mortality associated with the open repair, and there was no trend in the use of endovascular repair throughout our study period. But I think with these results, additional studies are needed to look at endovascular repair of these injuries in our unstable trauma population. And thank you for allowing me to be here.
Before we get to Dr. Rossi, can I get a smile in the picture for your boss? Perfect. I mean, this is a proof that you can actually get out of New Orleans in the storms. So
Yeah.
that's why I'll remind him later.
I was called Gray.
Mal will enjoy that. Sophia, that was really well presented. Thanks. One comment and one question. In your abstract, it's mentioned that hemodynamic instability seemed to be a good reason to go to open surgery. And I would sort of question that one a little bit. Hemodynamic instability is often controlled faster with a balloon rather than open surgical approach. But my question is, did you analyze any of your open surgical data by which segment of the subclavian was injured, like intrathoracic versus extrathoracic, pre or post vertebral? Because obviously those are very different injuries to control and repair, either from an open or endo approach. Did you look at anatomy or not?
I did not, but that is a great question. But I do, your point with hemodynamic instability not being a contraindication to endovascular repair is great, because I do think I've read papers where they have protocols and algorithms for patients that are unstable but do get endovascular repair.
Right. There are actually papers that show that for patients that are hemodynamically unstable, outcomes are better with endo rather than open. That's mostly lower extremity, but something to think about.
Yes, sir. Thank you.
Were you able to find a correlation between the surgeon on call? Because obviously time period, you didn't see it, but some guys and gals are older and younger and they adapt things a little differently.
Yeah, there definitely was a trend with physician preference. So I think that was a big thing in our institution.
All right. Thank you for your time.
Thank you.
All right, next up, we'll invite Hassan Chamsidine from Henry Ford to discuss total endovascular repair in ARCH TVAR is plagued by high stroke rates.
Thank you for the opportunity to present. We have no disclosures. Endovascular stent grafting of the aortic arch is becoming more prevalent but remains under study. Accordingly, the aims of the study were to first evaluate the outcomes of zone 0 TVAR for aortic arch disease, and second, to compare the outcomes between different techniques of head vessel revascularization. All patients receiving a zone 0 TVAR covering all the head vessels in the Vascular Quality Initiative were identified between 2014 and 2023. Patients were split and compared based on their head vessel revascularization technique, split into open revascularization, defined as the open revascularization of all the head vessels, endovascular revascularization, defined as endovascular revascularization of all the head vessels, and hybrid revascularization, defined as the stenting of at least one head vessel, followed by debranching of the others. A total of 382 patients with a mean age of 66 years were included, of which 32% were females. Approximately half the patient population received open revascularization of the head vessels, whereas a quarter received hybrid and a quarter received endovascular revascularization. Looking at the trends in utility, open revascularization decreased gradually from 83% in 2014 to 31% in 2023. On the other hand, endovascular revascularization increased from 13% in 2014. It peaked at 40% around 2020, but dropped down to 15% in 2023. Hybrid revascularization increased from 4% gradually up until 54% in 2023. Baseline demographics and characteristics were similar between the three groups, but endovascular revascularization patients were older and more likely to be white. Procedural details, including emergency status, pathology treated, and distal landing zones, were similar. Looking at the outcomes of the overall population, rates of stroke and myocardial infarction were 13% and 6% respectively, with a median hospital stay of 7 days. 30-day survival was 90%, whereas 12-month and 24-month survival were 82% and 77% respectively. When looking at perioperative outcomes, open revascularization had significantly the shortest time between the three groups. Nonetheless, ICU stay and hospital stay were similar. When discussing stroke rates, hybrid and open revascularization had stroke rates of 8% and 11% respectively, and those were significantly lower than that of endovascular revascularization at 22%. Moreover, open revascularization had the lowest rate of MI at 2% compared to endovascular and hybrid at 12% and 11% respectively. Nonetheless, when looking at the stroke rate over time, we witnessed a significant decrease in the endovascular revascularization stroke from 30% in 2017 to 2020 to 14% between 2021 and 2023. That of open and hybrid revascularization, however, remained approximately stable at 10% and 7 to 10% respectively. Finally, when looking at survival, within the first year post-op, survival curves were nearly identical between the three groups. When looking post 1 year, curves started to deviate away from each other, but this did not reach any statistical significance. So in conclusion, stroke remains a significant concern for patients receiving arch TVAR at around 13%. There is a wide variation between stroke rates between different head vessel revascularization techniques, with endovascular revascularization having the highest rate at 22%. 30-day and 1-year mortality rates remain high, and accordingly, further research and refinement of strategies are necessary to mitigate the stroke rate. Thank you.
For discussion, Dr. Cho.
Enjoyed your presentation. I just have one simple question. Did you see if there is any difference between the indication, such as atherosclerotic aneurysmal degeneration of the arch versus chronic type B dissection-related aneurysmal degeneration? Thank you.
Thank you, Dr. Cho, for your question. So for outcomes of zone 0 TVAR treated between atherosclerotic disease or dissection and aneurysmal disease, we did not look into that. All what we know is that those indications were balanced when we compared different head vessel techniques, but we did not look at each subgroup individually.
I think that's going to be an important thing for you to look at because we know the stroke rates are very different, and it's nice to get some benchmarks that you're establishing for all the new arch trials, all the devices out there and stuff. So
we will take this point into consideration with the manuscript. Thanks, Yana.
Perfect. Thank you for your time.
Next, we'll hear from Andrew Hung, outcomes of 2 decades of abdominal aortic endograft explants, risks that persist beyond the perioperative period.
Hey, my name is Andrew Hua. I'm one of the vascular surgery residents over at the University of Michigan, and today I'm presenting on our outcomes of EVAR explants from 2002 to 2024. So since the introduction of the EVAR in the 1990s, AAA repair is now predominantly endovascular at 74%. However, there's early survival benefit that's counterbalanced by late complications as death has been shown in large series of these patients. Over time, more and more of these EVARs have been implanted or are now in the community, and since then, they both have features that make them actively designed not to be removed, such as suprarenal fixation, as well as secondary procedures such as Palmaz stents or endo anchors. That makes it challenging to do explants and makes the procedure inherently challenging. So looking over a 22-year period, we had 142 explants at a single center. 100 of these were for a primary indication of endoleak. The other 2 were for a primary indication of infection. We looked at these 2 cohorts and compared them preoperatively, intraoperatively, and postoperatively. So preoperatively, the EVARs were predominantly placed at outside hospitals at 76%. This increased from the first decade to the second decade, from 67% in the first decade to 81% in the second decade. The primary indication for endoleak explant was type 1A as well as type 2 endoleak. Generally, the type 2 endoleaks were repaired at a larger size at 8.6 centimeters versus 7.4 centimeters for type 1A. And generally, infection had a shorter implant to explant time than endoleak. However, it should be noted that infection can occur at any point during the graft's life cycle. And there are no statistical significance to many other of the demographic features in our cohort here. Perioperatively, as may be expected, our infected explants took longer, about 2 hours longer, and was statistically significant. They're more likely to be urgent or emergent. And when trying to remove these infected endografts, if possible, all of the endografts were removed, but it's challenging sometimes with suprarenal fixation, as we found, versus the endoleak, where parts of the grafts were removed to resolve the endoleak and for a repair. And because cell saver generally cannot be used in an infected situation, more red blood cells were needed perioperatively. Postoperatively, for both cohorts, length of stay was long, but you can see that the infected patients had both a longer ICU as well as a hospital length of stay, nearly almost twice as long. There are no statistical significance for many of the common complications following these procedures. Although our infected EVAR explants were generally less likely to have a home discharge disposition. With regard to serious as well as death, serious complications as well as death, we did comparable to the NISQIP estimates. Our endoleak patients generally have a lower rate of serious complication and death in the 30-day period. Our infected EVAR explants generally had a higher rate of serious complication as well as death. However, looking past the 30-day period, if you look at the 2-year point here, generally both patients had poor outcomes at 2 years, and there's no statistical significance in terms of death for both groups when you hit the 2-year mark, which we thought was interesting. So, in conclusion for us, the message that we wanted to take away is that placing high-risk EVARs that either may be off IFU or may need an explant in the future exposes patients to a high-risk procedure that may be years down the road and has inherent risks both in the short term as well as in the long term after these explants. Thank you.
Dr. Pinos?
Very nice presentation. I wonder if you can share information with us about how did you reestablish perfusion after removing an infected endograft? Yeah. And what if there was concurrent infection of the native aorta and iliacs? Did you remove everything?
Yeah. Thank you for the question. Actually, if someone has my slides, I have another one with some tables that we can pull up. But generally, it was a just-in-case thing. But generally, we did in the first decade, I think there was a lot more NACE repairs and other repairs such as those. But generally, over time, we've switched to a Dacron-soaked within rifampin approach to repair, and it was generally inline flow for the majority of these patients rather than a Ax-Fem or something like that, which is not always the textbook answer for that.
And hi, John from Colorado. Great series of cases, and I think it's emblematic of a lot of our medical centers that see these quaternary patients and do these heroic things. I think you've convinced me that explanting an infected endograft is worse than explanting a non-infected one, but we all do that, right? What I'd like to know is, what are you doing for this 50% one-year mortality? It's my observation, Gretchen Schwarze, my former institution, there's a lot of momentum. When you transfer to the medical center, let's do something. And it sounds like you're saying a word of caution, that half of these patients aren't going to survive a year. So what factors can predict those half that we should probably not go and explant them for?
Thank you, Dr. Matsumura. I think that's a fantastic question that we've been discussing as well. And I think I want to extend your question to the endoleak patients as well, since both had pretty poor mortality in the long term. And we don't know. Looking at our demographics info, there really wasn't much of a difference, right? And looking at this cohort, I think we need to dig into what are the features, which ones are actually more likely to rupture, which ones are more likely to need treatment. And some of these patients are older and sicker and, just age, frailty, and looking at all of those features and figuring out, or long-term chronic antibiotics, can it be sufficient for some of these patients?
And you also, in your paper, you have to include how many people you saw that you didn't treat. Maybe you already try to pick the best ones and they still die half the time, which is pretty sombering. So, yeah. Good job.
Thank you.
All right, next up we have Indrani Sen from Mayo Clinic Eau Claire presenting preliminary report demonstrating feasibility of utilizing AI for imaging and biomechanical study of aortic aneurysms.
Thank you. Good afternoon. So as we all know, image automation in assessment of images of aortic aneurysms is happening, but has not yet become clinically applicable. There is a clinical need because we need more biomechanical data for analyzing progression of disease in women and in those with atypical morphology. So this was a multi-center study using images of patients over the last 2 years between 2 centers where we looked at demographics, aneurysm diameter at diagnosis, and the biomechanical wall characteristics. The methods included CT angiogram images being processed by computational flow dynamics, an initial manual segmentation process turned into a point cloud, a surface mesh, and then a volume mesh, following which these images had a boundary condition applied and stress analysis performed. A parallel pathway involved automated segmentation using convolutional neural networks, a similar mesh generation, which then was analyzed with machine learning models to then generate a stress prediction. The wall stress analysis was performed by setting boundary conditions to a pressure of 120 millimeters mercury and then using some preset protocols for analysis. Initial technical feasibility in the two institutional data sets was demonstrated in 390 patients. A majority were male, and the females in the set did present at onset with smaller aneurysms. This is a demonstrative case, an 83-year-old female who presents with a saccular aneurysm, and as you can see in the image progression, the traditional thought is that the most bulgiest part of the aneurysm is what probably has the most stress, but that isn't what this study shows. And obviously, this is early data. We don't really know how this translates into actual clinical practice, but that's what we hope to develop in the future. Some additional results comparing males with females, and again, as expected with the smaller aneurysm diameter in females, a lot of the characteristics, including lumen thickness, intraluminal thrombus, peak stress, mean wall stress, were different between males and females. So in conclusion, artificial intelligence algorithms based in image analysis holds promise and is likely to become an adjunct to help us clinically in developing patient-specific risk models. Thank you for the opportunity to present this work, and I welcome any questions.
I was going to ask AI to ask a question because this is too complex for me, but I have something better. I just texted Dr. Milner, so Dr. Milner after Dr. Shireen.
Thank you. So I love this. The question I had is the relationship between stress and the biological construct of the aorta, meaning can you infer the state of elastin and collagen, specifically type 1 and type 3, and how that is interplaying, and how can you take this information to infer that?
So we had thought of two possible ways. So one is when we do our open resection to send them tissue, and we're trying to see if we can build that pathway, and the other is MRI. But it's not done yet. But it can be done is the hope, and hopefully we have more.
Would love to talk.
Yes.
So John and I had a similar question, so I'm going to ask for him as well, but I have to make one snarky comment first, not at you. I'm going to...
Just the question, sir.
My conflict here versus Dr. Muck, who does not disclose his conflicts. My conflict here is I consult for a company that does something relatively similar to what you're doing. I think the hardest part of this has always been the time it takes to do these imaging, to be able to sit in a clinic and then take the information from this. But I think this is hugely valuable because just like Dr. Shalhoub was saying earlier, we see patients with 11-centimeter aneurysms that haven't ruptured, and we see ones with 4 that have. It'd be great to have this predictive tool, but it's not clinically relevant right now. We can't use it in the office.
I do agree, and I think that is the entire, that is why this particular tool is so awesome, because it shortens that process. Like, we can get this data within a day. That has never been possible. So I really think, and I know that the teams are working to make this commercially viable, so we can't give out too much, but it will happen.
Since you won 2 prizes, you get a question.
Really nice work. I can attest on how much time that takes, so congratulations. I know that was probably a tour de force. My question is related to the intraluminal thrombus, and if you looked at whether the wall shear stress was correlative to the volume or proportion of ILT?
Yes, it was. And actually, very surprisingly, the cutoff actually happened at roughly the cutoff diameters that we fixed them at. So when there were smaller aneurysms, obviously the ILT was lesser. It was lesser to begin with in men than in women. And then as they grew, the ILT volume grew, the wall stress grew, and Without the biologic correlate, really there's no way to split them to say which one is which, but for sure the computer would think that the ILT is protective, which I don't think can be true, but that's what, there is something that for sure changes there.
Great. Representative, thank you.
Thank you.
Next, we have Dr. Wei-Chen Hung, a comparative study of the complications of a human aortoiliac graft, a commercial graft, and a 3D printed graft in a mock circulation loop.
Hi, everyone. It's my great honor to be here to present my recent work. So the compliance mismatch between the native arteries and the prosthetic grafts will lead to some severe complications like the neointimal, like the neointimal hyperplasia and reduced graft dependency, and even like the pseudo aneurysm. So the objective of our research is try to explore whether the 3D printed artery could have a better compliance match to the human arteries compared to standard grafts like the PTFE graft and the Dacron graft. And here's the image of our lab benchtop setup. So we use a mock circulation loop to recreate the cardiovascular environment of the human artery. And this mock circulation loop can allow us to have a controlled experimental platform to test different types of cardiovascular grafts. And we have the 3D printer from Formlabs company, and it allows us to test a number of different polymer materials with different mechanical properties. And the highlighted one is called the biomade elastic resin, which shows the smallest mechanical strength and will lead to the highest compliance property. So that's the one we use for the comparison to different types of aortic model. And here is the pressure waveform comparison for 4 types of models, includes the PTFE, Dacron grafts, and the biomade elastic resin-based 3D printed model and the human arteries. And we can find out the 3D printed model in black color has the coldest match to the pressure form of the human arteries in red color. And here's the summarized table, including the compliance value calculation and some other hemodynamics measurements. And we note it shows that the biomade elastic resin-based aortic model has the higher compliance value compared with the PTFE graft and Dacron graft. It also shows more, something wrong here. It also shows more similar hemodynamic behavior to human arteries, includes the post pressure and the mean arterial pressure. However, there's still some problem that the 3D printed model is still stiffer than the human arteries. So in conclusion, it's very promising for the 3D printed artery construct with the biomade elastic resin can show better performance compared to some standard grafts. And some ongoing research includes the investigation of the biocompatibility and durability of more new polymer materials and in the animal model. And also we will try to find more real applications of these 3D printed arteries in like surgical. And yeah, that's all. I'm happy to take any question.
Great, thank you. Open to the floor. I'm not too familiar with, I'm probably going to say the strong bioelastic resin. Is that something that we typically use already in the human body, or is that completely off?
So no, it's just a kind of commercial resin provided by the Formlabs company. And it's biocompatible, but we didn't do any test yet, so we don't know if it can fit human body or not.
Gotcha. When they say it's biocompatible to what? To like animals so far?
Yeah, but it's, yes, for the animal, and it's like some commercial saying of the company, but we need to do the test by ourselves to prove that.
You can't trust those companies. They make
Of course.
things up. So,
I
all
have
right.
a quick question about the material itself. How's the suturability with it? Is it able to hold suture? Is there a certain type of suture that works better with this material?
It's type of suture. Yep.
Nice.
I have a question. With your human control, how did you prepare that artery?
So we have, first we grab some standard graft like the PTFE and Dacron graft, and we design and print this exactly the same geometry as that standard graft. And also the same geometry to the human graft. And we do the test on the musculation loop to collect some hemodynamic measurements and also do the compliance calculation.
Thank you.
Thank you.
Thank you.
All right, next we have Yinjin Hong of the University of Missouri. They're presenting the disparities among homeless patients undergoing open lower extremity bypass procedures.
Okay, first I would like to thank the committee for allowing me to present this study, which details, first, we see that homeless patients tend to have health challenges that increase their morbidity and mortality, and this is pretty well known. Although there have been few reports assessing the impact of housing status specifically on vascular surgical outcomes, which is why we wanted to investigate the disparities in mortality and readmission among homeless adults undergoing open lower extremity bypass. And we did this by doing a retrospective cohort study using the National Readmissions Database. Between the years 2018 to 2020, about 58,000 patients were identified using ICD-10 codes, and these patients all underwent open lower extremity bypass procedures, about 269 of which were homeless. Our primary outcomes included inpatient mortality, 30-day readmission rates, amputation rates, and length of stay. And additionally, just some demographics here, we see that homeless patients tend to be significantly younger. Homeless patients also tended to be male and have a greater degree of illness severity. Additionally, homeless patients tended to come from large metropolitan areas, while those who were non-homeless had a higher rate of elective readmission. Primary outcomes that here include no statistically significant difference in inpatient mortality. However, homeless patients did experience a higher rate of amputation as well as a higher 30-day readmission rate. Additionally, we found that homeless patients tended to have a higher total number of hospital charges in addition to a higher number of procedures, a higher number of diagnoses, and also a higher hospital length of stay on average. Comorbidities tended to be varied here. Homeless patients tended to have higher rates of CHF, but tended to have lower rates of COPD and diabetes. But we do see that homeless patients tend to have increased rates of increased illness severity. So in conclusion, we found that homeless patients undergoing open lower extremity bypass presented with increased disease severity, received a greater number of interventions, all contributing to a greater utilization of hospital resources. Although mortality rates were similar between cohorts, we found that homeless patients did experience a higher 30-day readmission rate, a higher amputation rate, and also leading us to conclude that housing instability was associated with increased morbidity and financial burden on the healthcare system. Thank you so much for your time.
This paper is open for discussion.
Great work. I think it's very interesting. One of the questions that I had was there a difference between, or were you able to look at the time between medical readiness for discharge and the patient's actual discharge? We always have disposition issues with patients of lower socioeconomic statuses. Did you see that kind of in this population as well?
That's a great point. Unfortunately, the National Readmissions Database was not able to track that in an administrative database, and I'm sure that may be one of the issues with administrative databases is sometimes we can't get into the granular data. Although we found that, and I certainly believe that readiness for discharge was one of the factors contributing to increased length of stay. And we can see that with like the higher readmission rates even, because readmission rates among homeless patients are so high, sometimes readiness for discharge can potentially be something we target as a potential for improving these statistics.
So I have a question. Were you able to tell the causes for the higher rate of amputation? Was it wound infections, bypass thrombosis, inaccess to medications that they needed, that sort of thing?
Yeah, so we did multivariate analysis, actually. It wasn't presented in this talk, but we'll present it in the manuscript. Certain factors was associated with amputations. Interestingly, lower median household income and insurance by Medicaid, those were two of the factors in addition to several complications. Hemorrhage as a complication, for example, was definitely. And illness severity. Illness severity was also a risk factor for amputation. So we'll be sure to present those in the final manuscript.
I think it would be interesting for you to look at, the rates of primary amputation in this population, because I think, you need a lot of resources to carry somebody through a bypass. So it would be interesting to see if your rates of, percent of people with homelessness is actually way more than 0.5% for people getting primary amputations. But great job.
Thank you.
Next, we're going to have Melissa Day, the role of open abdominal aortic aneurysm repair in the era of fenestrated endovascular repair.
That looks like a Ryan Ellis coming up.
I'm sorry,
It's all good.
Ryan Ellis.
Sorry for the letdown. Dr. Day is here. Thank you for being here, Doctor. Okay. My name is Ryan Ellis. I'm a general surgery resident at the Cleveland Clinic PGY3, and thank you for the opportunity to present our work. Here's our list of authors and our disclosures. So abdominal aortic aneurysms, AAAs, are present in approximately 4.8% of the population, and this number is believed to be increasing with the overall average lifespan, improved diagnostic modalities, improved screening programs. Since the 1950s, open surgical repair was the mainstay of AAA treatment until endovascular repairs began to take traction in the early 2000s, which caused a big paradigm shift. Today, more than 80% of AAAs are treated endovascularly. However, patient anatomic suitability remains a significant limitation to endovascular techniques. So modern techniques and devices such as the fenestrated EVAR have been developed to address these limitations. So the question we wanted to answer is there a role for open aortic repair at a quaternary institution with the availability of a variety of techniques? So we performed a single institution retrospective descriptive study over a 10-year period of adults undergoing elective open AAA repairs, and we excluded prior EVARs, emergent repairs, and any isolated iliac aneurysms. So over 2,700 patients underwent a AAA repair during this time period, and using CPT codes, we were able to find that there were 849 patients that met this criteria. The patient granular data was abstracted with chart review, and the preoperative CT scans were evaluated using TARE Recon, and the measurements were taken based upon the IFU anatomic exclusions for FEVARs. So here's the breakdown of the patient demographics, the mean age of 69. Most patients were tobacco users with hypertension, hyperlipidemia, and chronic kidney disease. The mean aortic diameter, the aneurysm diameter of this patient population was 5.8 centimeters. The neck length was 12.4 millimeters, and the angulation of over 32 degrees. Looking at these specific anatomic exclusions, looking at this retrospectively and putting this all together, these patients had over 59% had an aortic neck of less than 4 millimeters. And 59% as well had iliac artery tortuosity of greater than 40 degrees. So overall, 92.6% of these patients met at least one anatomic exclusion to the use of FEVAR. And in conclusion, in this population, the vast majority still had at least one anatomic constraint requiring an open repair. And despite the availability of new devices and new techniques and amazing things that we've seen this weekend, I think there's still a significant need for open aortic surgery. Thank you.
Thank you. Open to discussion.
You can add not melissidate to that.
Yeah, right.
Sorry.
Dr. You're good at me, I'm sure.
Yeah, you might not.
That in there. So, looking on here, obviously, most people are very, when you look at specific IFU, you're right that most of your patients don't fit it, but not to say that's okay to adjust it. But your institution also previously had access to IDE and more advanced devices. Did you see some changes over the time course and, again, distribution of physicians to see a difference in the decade that you looked at?
Yeah, we didn't break it down based on the time point. I think that would be interesting. And in fact, one of the things that I did want to mention is based on the IDE, I think the next step for this is looking at outcomes, seeing how these patients did. And I think to compare our group with those under the IDE would be an interesting comparison because they should meet similar anatomic criteria that we're receiving endovascular treatment.
Dr. Miller.
Sure.
We're very limited in the U.S. with the devices we have. And this same study doesn't need to be done in Europe and other parts of the world because they actually have devices that can treat these limitations. And I think when we talk about advocacy, like we talked about yesterday, this is something that we struggle with our FDA approval process. We have a huge limitation with devices, impacts patient care in a really negative way. And in Europe, they do infrarenal aneurysms open. They do everything above the renals, endo, because they have devices that can do it right.
100% agree. Thank you.
Great. Thank you for your work.
Next, we have Dr. Debbie Lee from Loyola University discussing social determinants of health and hospital volume do not impact outcomes of fenestrated endovascular aortic repair.
So tall. Good morning. Thank you for the opportunity to present. I'll be discussing our project looking at social determinants of health on outcomes in this patient population. Endovascular repair of aortic aneurysm involving the visceral segment carries high procedural complexity and increased adverse event rate than standard infrarenal EVAR. Fenestrated endograft has higher cost and is typically performed in fewer high-volume centers. There is a leapfrog concept for referring complex patients to high-volume centers across different surgical specialties. However, social determinants of health, including economic status, insurance, where the patient is from, can impact access to these high-volume centers. Little is known about these factors and their impact for outcomes as well as access in this patient cohort. The objectives of our study were to investigate the impact of social determinants of health on access to high-volume centers, determine the clinical outcomes in fenestrated abdominal aortic endovascular repair, and finally assess the effect of center volume in fenestrated endografts on clinical outcomes. So we used the VQI, TVAR, and complex EVAR datasets to evaluate 4 outcomes. 1, those who were lost to follow-up in VQI at 1 year. 2, 30-day operative mortality. 3, a composite perioperative adverse event outcome. And 4, 12-month mortality. When looking at the impact of social and demographic variables on outcomes, we found that those who lived in rural areas, as well as those who had military or VA insurance, were more likely to be lost to follow-up at 1 year, while the other variables did not have an impact. As in addition, those from most deprived ADI cohorts and Medicaid patients were treated in lower mean case volume centers. In our figure 1, looking at the clinical outcomes in this patient cohort, we found that there is a stepwise increase in adverse event rates with increased number of fenestrations. However, when looking at those who had 3 or 4 fenestrations, there was actually no difference based on center volume. Finally, on our multivariable logistic regression, we found that female gender, end-stage renal disease, chronic renal insufficiency, as well as increased number of fenestrated had increased odds for adverse perioperative event rates. However, interestingly, the center volume as well as the social determinants of health factors did not increase the odds for worse perioperative adverse event rate. In conclusion, social determinants of health and center volume did not impact the outcomes in this patient cohort. The female genders did have a worse perioperative outcomes, and there were progressive morbidity and mortality in increased visceral vessel fenestrations. Thank you. Happy to take any questions.
Dr. Rossi?
I have one question and one comment that's really well presented. So my question is, within VQI, how did you get it? Who was lost to follow-up, and what centers just don't enter follow-up data? And that's one thing we've been struggling with a lot as we rewrite the aortic database in VQI is, they're just centers that simply will put the index case and then add nothing. So how did you determine that?
That is a fantastic point, and unfortunately that is the one inherent limitation within the VQI that unfortunately we don't have the data follow-up, and within this study at least we only used the VQI data set, and we limited to patients who had follow-up up to that 1 year and excluded patients who did not have any information with, prior to that 1 year. But I do think that additional information, such as using the VISION data set, could potentially help to increase what we can find out.
Yeah, and just to sort of pile on what Ross said earlier, a lot of the world has access to devices that we simply don't have here. But this, probably the more important finding of your study here is that it's time for PMEG to come out of the shadows, right? There's absolutely no reason we shouldn't be talking about this. 90% of the geographic population of this country has no access to ARC centers. So this is going to be very important data. Thanks for presenting that.
Absolutely.
One question I was going to ask you, though, your finding at the end was that there's no difference, which is very different than what you think of, healthcare disparities in every other disease model. Is there something we're doing different with these patients? Because do we favor following them more carefully, arranging outreach visits, getting CT scans somewhere else, and being much more careful? Because this is not probably what your hypothesis was going in.
Absolutely. This was definitely not what we hypothesized when we started this project. So we definitely thought that patient from, or higher ADI or worse socioeconomic status would have worse outcomes. But, this project basically is showing that, patients may have been appropriately referred to a higher volume center, and that those patients that were from rural areas, as well as those who had military insurance, of course, were more likely to be lost to follow-up. So I do think that this project is teasing out something that we should focus on.
Great. Thank you. Great job.
Dr. Tien's going to present evaluation of the dynamics of bone oxygenation during stress testing, a novel perspective on approaching diabetes and peripheral arterial disease.
Thank you for the great opportunity to present. My name is Yuqian Tian, and I'm a general surgery resident from University of Nebraska. So we're honored to present our study today, the evaluation of the dynamics of bone oxygenation during stress testing, a novel perspective on approaching diabetes and peripheral artery disease. These are our disclosures. So through clinical experience, we recognize a critical gap in predicting tissue healing potentials among patients with diabetes and peripheral artery disease. The current gold standard, transcutaneous oximetry TCPO2, is limited because it only provides information regarding skin oxygenation, leaving us in the dark regarding tissues, including muscle and bone, how they do. To bridge this gap, our group has previously used a near-infrared spectroscopy NIRS device to assess muscle tissue perfusion, both at rest and under ischemic stress. So this study, we turn our focus to bone tissue. We're hoping to assess bone and muscle perfusion simultaneously in a swine model during the post-occlusive reactive hyperemia test using NIRS device. So we used 7 ossable swine with metabolic syndrome in total for this study, and we have placed NIRS devices, as you can see in the picture, bilaterally on the gastrocnemius muscle below the knee, as well as on the lateral side of the metatarsal bones. And to conduct the post-occlusive reactive hyperemia test, we did an open cut down on the right carotid artery, placed a 5 French Fogarty balloon in the infrarenal aorta, and then inflate the balloon with the angio to confirm complete occlusion, and allowed this complete occlusion for 5 minutes, followed by balloon deflation. This test allows us to capture real-time data before, during, and after this ischemic event. And this is a typical oxygen dynamics that we see captured by NIRS device from the muscle tissue that you can see the tissue oxygenation drops and plateaus during the occlusion phase and then slowly recovers back to baseline, followed by hyperemia phase. So this is our key finding from this study. As you can see, during the occlusion phase, the bone in red showed a significantly smaller oxygenation drop compared to the muscle in black, as well as overall smaller oxygen deficits during the occlusion phase. However, in the recovery phase, the bone recovered much slower than the muscle, taking an average of 115 seconds to recover back to baseline, rather than just 38 seconds for the muscle tissue. So based on this data, we conclude that bone behaves very differently when compared to muscle tissue during the post-occlusive reactive hyperemia test, suggesting distinct metabolic demands and stress response. And understanding the oxygen supply dynamics of different leg tissues, we believe, may help us build a more comprehensive model to predict healing after amputation or revascularization operations. Thank you very much, and I'm happy to take any questions.
Dr. Cho?
I enjoyed your group's presentation from Thursday and again today.
Thank
I
you.
have 2 questions. One, how sure are you that you are actually measuring the bone oxygen saturation as compared to the surrounding tissue? And the second question is, you measure the muscle in the calf and the supposedly bone in the foot. Why not at the same level? Do you think there's any difference because of the difference in the level that you're measuring? And the third is, what's the clinical implication? Thank you.
Thank you for your questions. So for the first question, sorry, I'm trying to recap all the questions that we had.
How do you know it's bone?
How do we know it's bone?
Yeah.
So we are fairly confident that this is bone for several reasons. First, because of the specific position, that the location that we chose to position that device, that the bone is directly underneath the skin without much other soft tissue around it. And we have confirmed that through dissection when we sacrifice the animal to confirm the bone is directly underneath the skin. We also actually have collaborations with other physiologists who is doing very similar studies on bone health, bone blood flow with other bones in the body in human subjects. And their findings actually correlate very well with what we found in terms of the differences between muscle and bone and just the bone dynamics during this during the whole study. And for the second question regarding position of the devices, simply technically, it's very challenging to place the 2 nearest devices really close to each other because the light emitting from one device very easily could be captured by the other device and interfere with that results. And we wanted to study the distal bone, so that's where we put our first devices. And unfortunately, we have to kind of move up our muscle devices so that to allow accurate measurements. And in terms of a clinical implication, one of the important studies that we think would help us to better understand in the future that we plan to conduct is to recruit patients prospectively and for people who have complex distal foot wound with diabetes or peripheral artery disease, or plan to have a toe amputation that we know will have a wound to heal, and then we can collect both TCPO2 as well as the nears of the muscle and bones when at rest and at stress, and then kind of follow along the way to see how well the wound heals to evaluate of which of the tissues would be the best predictor for wound healing.
Great. Thank you.
Thank you.
Next, we have Arjan Khan presenting trends in Medicare spending on PGY12 inhibitors and direct oral anticoagulants from 2018 to 2021.
Hello, everyone. My name's Arjan Khan. I'm a 4th-year medical student at the University of Medicine and Health Sciences, and I'll be presenting trends in Medicare spending on P2Y12 inhibitors on direct oral anticoagulants from 2018 to 2021. I have nothing to disclose. So P2Y12 inhibitors and direct oral anticoagulants are medications that are used for a wide variety of cardiovascular conditions. There's limited data, however, that kind of explores the total healthcare spending of these medications. And in our study, we investigate the recent trends in Medicare spending to examine potential cost reductions for patients as Medicare beneficiaries. So we used the online publicly accessible Medicare Part D data set for the specific calendar years of 2018 to 2021. And the specific medications that we looked at were Plavix, generic clopidogrel, generic prasugrel, Effient, Brilinta, dabigatran, rivaroxaban, apixaban, and edoxaban. If we look at the blue bar graph, that represents the total healthcare spending. The left side is from 2018, and it goes up to 2021. We can see that the total healthcare spending has increased significantly, and it's increased by 197% over those 4 years. But that does not parallel the increase in claims as well as the increase in beneficiaries. When we look at this table, we look at each specific medication and their total spending, the beneficiaries, and the spending per claim. And we can see that the medication with the highest amount of beneficiaries and that was prescribed the most was Eliquis and generic clopidogrel. The medications that actually had a decrease in total spending per claim were generic clopidogrel and prasugrel, whereas the medication that had the greatest increase in spending per claim was Effient and rivaroxaban. In conclusion, what this study kind of tells us is that it shows us the recent trends in total healthcare spending and beneficiaries as well as claims for these specific medications. The 197% increase in total healthcare spending does not parallel the increase that we see in beneficiaries, which is roughly around 29%, and the increase in claims, which is around 22%. And that tells us that higher costs rather than higher use is the main contributor to the increase in spending. And future research, we would like to kind of conduct cost-effective analysis of these medications and see what the out-of-pocket patient spending would be to investigate the economic impact for patients and for healthcare policies as well. Thank you.
This paper is open for discussion. So you know, with a lot of medications, as always, when you sort of have it at the beginning, there's a much higher premium, and some of it transitioning to generic medications. How are you going to account for some of that? And also, you know, practice guidelines evolve over time as well. How do you kind of put that all together?
There's no specific, I guess, in the Medicare Part D data set, it didn't really go over what the premium was for each specific medication, or it didn't really go over what the out-of-pocket spending was for patients, which I think would be really important to investigate. And there are cost-effective analysis for these medications, but they're a lot earlier, like around the early 2000s, which isn't kind of isn't beneficial to our current year.
Now, yeah.
Yeah.
Dr. Claire?
Recent trials that have shown an advantage to dual pathway inhibition, so using platelets and antiplatelet and anticoagulants. Did you notice over this time frame that there was a decrease? Were you able to look at, is there an increase in the use of the DOACs as opposed to Plavix as a secondary measure for vascular therapy?
That's not something specific that we looked into, but I think that'd be a good thing to specifically look into.
That's something you want to look at because your study went to about 2021, and I think the practice in the past 3 years has changed a bit. So great job. Thank you.
Thank you.
Next, we're going to talk about stage venography following thoracic outlet decompression is effective for venous thoracic outlet syndrome with Dr. David Schoen.
All right, good morning, everyone. Thank you for the opportunity. I'm David from the University of Chicago and North Shore University Health System. We have no disclosures. So the management of thoracic outlet syndrome is really pretty complex, and I think that there's a bit of a lack of consensus across institutions on the best way to take care of patients. And so we wanted to share our experience doing a staged approach for the management of patients with venous TOS. Patients that present with acute thrombosis or Paget Schroeder's are treated with thrombolysis or thrombectomy and then anticoagulated for about 4 to 8 weeks, typically with a DOAC, and then they're brought back for decompression. We have a couple of patients with McCleary syndrome without acute DVT that were treated in a similar way, just with decompression and no anticoagulation. All of these patients are maintained on anticoagulation post-operatively, and then we bring them back for a venogram and venoplasty in a staged fashion as opposed to at the index operation. This is a single-center retrospective trial of 45 patients, the majority of whom had Paget Schroeder syndrome with acute DVT. The mean age was a little bit older than your typical population of around 42 years, with a predominance of males, which is also somewhat atypical. Non-dominant laterality for TOS was seen in about a third of patients, and interestingly, a fifth of our patients had concurrent neurogenic symptoms. Median duration of symptoms was 4 days, which is in line with the Paget Schroeder type etiology, and a DOAC was used in about 86% of patients. It's interesting to note also that around 15% of our patients with Paget Schroeder also had concurrent PE, which is substantially higher than some of the literature results that report around a 5% incidence of PE in these patients. Mean operative time was relatively short, a little bit less than 2 hours, with a low length of stay, just a little bit more than a day. We found that operative time was not significantly different between patients with Paget Schroeder versus those with McCleary syndrome. The presence of neurogenic symptoms also did not add time to the operation, and we had a relatively good low complication rate of 1 pneumothorax and 1 hematoma, both of which resolved. In terms of our outcomes, we had excellent outcomes from this cohort. 5 patients, in fact, had widely patent axial subclavian veins at their post-op duplex and didn't require any further intervention. Of the remaining cohort, 84% underwent a venogram, and 28 of those patients needed a venoplasty of some sort. This was much more common in patients with Paget Schroeder's than McCleary syndrome, 71% to 14%. In terms of our long-term outcomes, we found that at a mean follow-up of 457 days, around 90% of these patients had venous patency, were asymptomatic, and fully functional. So our key takeaways from this case is that the staged approach for thoracic outlet syndrome is effective and it demonstrates good long-term patency. It was safe with minimal complications and relatively quick operative time. Thanks so much.
Just coming up to the mic.
Great paper. Thanks for presenting that data. I think that a lot of us struggle with the best way to manage these patients. I also prefer to try to separate the venogram from the first resection, but sometimes logistically it can be tricky and things like that. Is there any, one argument I've gotten from patients is they just kind of want to be done, right? They already waited 4 weeks to 8 weeks to get their rib out. Now they're going to wait another 4 to 8 weeks to do their venogram. Have you gotten any pushback, or do you have any advice on what to do in those situations?
Yeah, I think it's a really valid point. And I think from our perspective, we sort of counsel them that doing it in a delayed fashion, we think decreases the inflammation in the thoracic outlet, and it's just generally a safer procedure for them. I know there's large trials out of institutions that show that doing it in one admission is safe and feasible. But I think especially we've been using a lot more DOACs than patients that used to go home on Plavix and whatnot. So I think we're seeing a lot less rethrombosis, and that's just a generally safer way to do it.
Have you had any patients who came back with the interval rethrombosis, and what do you do for those? Thank you.
Yeah. In this cohort, we haven't yet. And again, I think kind of owing to the last paper touched on this as well, like with the use of DOACs more widely for a lot of vascular disease, I think we're seeing less rethrombosis.
Excellent outcomes. Thank you.
All right, and next we have Carl Schofrister presenting extracorporeal membrane oxygenation use in open thoracoabdominal aortic aneurysm repair.
All right.
Hi everyone, I'm Carl. I'm a 4th-year student at MCW. Thanks for having me, and thanks for sticking around.
We locked the doors so they couldn't leave.
Appreciate it. All right, so this is our center's experience using VA ECMO for open thoracos. So open thoraco repair is an operation that carries significant morbidity and mortality risk, And a big driver of that is the use of cardiopulmonary bypass when it's required for these operations, as you can develop coagulopathies and you have to have hypothermia. And distal perfusion during open thoracic repair is commonly done by either cardiopulmonary bypass with deep hypothermic circ arrest, or if you don't need to do circ arrest, you can do left heart bypass with mild hypothermia. However, both of these cases, you have to have a venous reservoir, which requires a relatively high ACT, which can have a sequelae of potential complications, prolonged bleeding time, prolonged operative time, as well as having more air-blood interaction, which has been shown to cause some more inflammation. So a novel method for distal aortic perfusion has been the use of VA ECMO, with only a couple of cases previously described. So here's our center's experience doing it for 4 patients. And the general operative approach was a distal to proximal reconstructions, in other words, like a bottom-up build. And venous cannulation was done via the femoral vein, and then arterial cannulation just depended on the specific type of repair that was being done. And the bypass circuit was configured to run as ECMO by using a standard cardiopulmonary bypass pump, but you clamped off the venous reservoir, which you can kind of see on the screen. There should be more pictures in the manuscript. And ECMO flow rates were titrated to a MAP goal, and then an ACT of 220 to 240 seconds was used. So the average age of patients was 59 years old, which reflects patients that we deem suitable that could undergo an open thoracic repair, right? A little bit more younger and healthier types of patients. 50% were female, and then just the graphics showing the extent of repairs. Only one patient had significant postoperative complications, patient number 3. This was a redo open extent 3 repair after a visceral patch aneurysm developed on a prior open extent 3 repair. And then only one patient was an extent 2 repair, which is the largest extent of an operation you can have. And that's reflected with the longer ECMO time, the longer operative time, more products needing to be transfused. And all the other patients were extent 3s. Overall, this has been successful at our center for distal aortic perfusion during open thoracic repair. And it may have significant advantages over left heart bypass, such as decreased intraoperative blood loss because you can run a lower ACT, less postoperative coagulopathies because you don't have the air-blood interaction, and then you can maintain normal thermia as well. However, this is just 4 patients, and we didn't directly compare it head-to-head with cardiopulmonary bypass. So we think that further prospective comparison, matching against cardiopulmonary bypass is warranted to determine the feasibility and use of this. Can you take any questions? Thank you.
Thank you. I think I'm going to have to ask you, Peter. You got to help me understand. When you say left heart bypass, normally, to me, it means biomedica's pump, which does not require reservoir. And standard ECMO also does not have reservoir. So when you're saying the inflammatory response from using cardiopulmonary bypass, because obviously the blood exposure to the non-endothelial surface is much higher with the pump, standard pump. So I don't know what I did not understand when you said left heart bypass in your case, because to me, that's the use of biomedica's pump. And the only difference between biomedica's pump and ECMO is that ECMO has a heat exchanger. And ECMO is also a closed circuit, so you cannot suction any blood back into the reservoir. So the reduced blood loss that you're talking about, I don't understand. So you need to help me understand that. And well, let's start with that.
You got that one?
I guess reduced blood loss, I think they were saying more in the terms of you can run a lower ACT, so you would have less, intraoperative bleeding, and hopefully then you would have less operative time. And I'll defer to Dr. Rossi for.
Right, so the people that have the reservoir, the people that you're doing on left heart bypass with the reservoir when you're using the pump suckers, and running an ACT of 700, 800, 900, which is what they tend to do, as opposed to running 200 to 240. The coagulopathy bleeding is tremendous with the left heart bypass compared to the ECMO circuit. What we're doing with this actually is we are using the biomedica's pump, just cutting the reservoir out. That way, if we feel the need to convert for some reason, we can actually go back, put the reservoir in if we have to, but we leave it out to start.
So when you're saying left heart bypass, you're using actually a 4 Harlem machine. right? So it may be a matter of a difference of semantics.
Yeah.
But
So I think this is going to be much better served with you guys can have it over lunch, because all the students, you guys caught all that. I expect you to know that. We have a different question up here, though, if it's okay.
Thank you.
Yeah, thanks.
Hi, I'm Maggie Riley from Northwestern University. Great presentation, Carl, and looking forward to you applying to vascular this year, which is exciting. I have a question about, can you speak a little bit about the training of the operative team that this requires? Like in our vascular ORs, if we suddenly told them that we were going to use ECMO, I don't think our nursing or anesthesia team would be prepared to deal with that. So can you speak a little bit on that?
Yeah, I mean, I think open thoracic repairs in general, well, my experience is lacking, but it is definitely a collaborative approach requiring, cardiothoracic team, your vascular team, everyone has their fellows. When I'm in the OR watching this, I'm just trying to find a good vantage point to see over everybody. But, with the CT team having their, commonly using cardiopulmonary bypass and having the perfusionists with them, I think the perfusionists play a huge role in this, and they, provided the pictures and some insights for help with this report as well. So I think, cardiac uses cardiopulmonary bypass more, so relying on them and their insights, working with the perfusionists, and just having a really collaborative approach.
Yeah,
Dr. Rossi.
just very briefly, I send out an email with the case plan the day before. We include cardiac surgery, perfusion, OR staff, everybody, and we do a morning huddle ahead of time, so we all know what the plan's going to be.
It's probably not very different than when you normally do your open thoracos anyways, with the perfusionists, cardiac surgeons, and everything. So hopefully saving some time for, you got one more question.
Just one more question.
You're keeping them from leaving.
I know, but I think it's kind of an important and interesting question. You mentioned maintenance of normothermia during these procedures, and typically we have found that hypothermia is actually helpful in preserving spinal cord perfusion and reducing the risk of spinal cord ischemia. So I was wondering, in this case using VA ECMO, if you could kind of weigh in on the possibility of normothermia and how that might impact spinal cord ischemia.
Yeah, that's a good question.
No spinal cord in this. 0 out of 4 is good.
Yeah,
one last answer.
Yeah. Is that like perfusing the pelvis more? Or?
We do passive hypothermia, but with the heat exchanger, it allows us to actually warm back up as soon as once we start our viscerals, we start warming back up right away. So we do passive for the first part of the case, then get them warmed up.
All right, we're gonna wrap it up there. I think we will have a special session outside for everybody to continue this discussion. So I'm going to call Dr. Muck here as the president to kind of wrap up this meeting because everybody's anxiously looking at their watch.
That's right. Thanks, JJ. A few things. Just want to say thanks, everyone, for staying to the end here. Thanks to our visiting professors. These lectures today were awesome. Congratulations to Bernadette on an incredible presidency and a great address yesterday. And I think we need to take a moment and thank Dr. Milner for this is his third and final program that he's run. And Ross, you've done an incredible job the last 3 years, so thanks so much. And then finally, I just want to say how excited our group is to have everyone next year in Cincinnati. It has not been to the Queen City since 1994, so we're super excited. There's a lot to offer. Downtown's fun, pretty, safe. The hotel's incredible. So I hope to see you all there next year. In the interim, if you have any ideas as the president, something you want to see the society do, please reach out to me. I'm happy to help. So until then, the meeting is adjourned. Thank you.